Dr. Eric Garland, thanks so much for coming on the show today.
Thanks for having me.
Yeah, well, truly it's my pleasure. As I mentioned a few minutes ago, I've been a fan of yours. I've been following you for a while because in the area of opioid use disorder in particular, there's shockingly few evidence-supported psychosocial treatments. We have treatments for different types of addictions that are pretty well validated, but opioids, it's been a tougher nut to crack. And the work that you've been doing actually is one of the few where very consistently over the years you have produced favorable results. So I'm hoping you could talk to us a little bit today just to get the conversation started about your therapy more, your program, how it came about, and we'll start with the basics. What should we know about it?
Great. I'd love to tell you about more. So, mindfulness-oriented recovery enhancement, or more, is my baby. I've worked for the past 15 years to develop and test this therapy. And really, what more is it's a structured program that integrates three great traditions within psychotherapy: mindfulness training, cognitive behavioral therapy, and positive psychology. And Moore weaves these components together into a neuroscience informed approach to addressing not only addictive behavior and specific to what we're talking about today, opioid use disorder, but also the comorbidities that we know that are driving addictive behavior, such as psychiatric distress and chronic physical pain. Uh, so Moore tackles all of these things at once. It simultaneously addresses addiction, stress, and pain. And so that's really useful, I think, because we know that these comorbidities, they're not the exception, rather they're the rule in this population.
Mm-hmm. Well, absolutely. So I'm curious, you mentioned those three foundational types of therapy: cognitive behavioral, mindfulness oriented work, and positive psychology. I feel like each of those individually hasn't shown the same level of effectiveness as Moore has. And I'm wondering, is there something specific about the combination of the three that you've found that's making Moore work where the other ones haven't had the same positive effect that ideally we'd find from someone going through a therapeutic program?
Yeah, great point. I think what makes More unique is really the synergy of these components working together in concert. And I think that's necessary when we consider the the mechanisms, the cognitive and the neurobiological mechanisms that are driving this problem. And what More really does, I think that is unique, is it addresses the core neurobiological deficit that is driving opioid use disorder, which is we know that as a person becomes more and more addicted, there are changes that happen in the reward system of the brain such that the brain becomes more sensitive to stress, pain, and drug related cues. And at the same time, the brain's reward system becomes less sensitive to the natural, healthy pleasure and meaning derived from uh, the people, the activities, and the values that the person once cared about. So the parts of life that were meaningful, that gave the person a sense of well-being or pleasure, they become less so as the drug takes central stage. And so this insidious process whereby the reward system becomes dysregulated really mires people in the cycle of addiction because the person feels like shit. They have a total hole inside of them. And so they're scrambling to try to fill that emptiness. And so to do that, they take higher and higher doses of the drug, which maybe temporarily works, but ultimately what it does is it further dysregulates the reward system. And so the person becomes ensnared in this downward spiral of
Mm-hmm.
suffering. So really what Moore is doing that I think is different than these other therapies, but draws upon their basic principles to accomplish this, is in Moore we aim to restructure reward processing in the brain to help people to shift back from valuing drugs back to valuing natural healthy rewards and thereby remediate this reward deficit. And so we do this in More through a combination of mindfulness, reappraisal, and savoring skills. And I can tell you more about that when you want.
Yeah, no, I definitely would like to hear more about them. I mean, I think I know we were speaking a little bit before the show that right now you're thinking about, so how do you get more out there so that people know more about the principles? I know you have a book coming out soon, and we can talk more about that as well. But I think understanding the mechanisms psychologically about how do we achieve these neuropsychological outcomes, how do we achieve these behavioral outcomes, like that's everything. I think that from a practitioner standpoint, when people understand why they feel the way they do and start to recognize what some of their levers are, like, oh, if I do this, I have this feeling be different, or oh, the craving has less traction on me, whatever it is, that's essential. So yeah, if you'd be willing to explain a little bit more about how do you restructure the reward, how do you use those different levers in order to achieve the result that you're looking for, that'd be
Okay,
great.
great. Let's talk about it. So the foundation of more. So more is a sequence treatment, and it begins with the foundation of mindfulness training. So mindfulness training is exceptionally important in this process of recovering from opioid use disorder because addiction really involves the development of automaticity. Addiction on some level is an automatic habit. People, through repetitions of taking the drug, cues that are associated with the drug become triggers that can activate craving and really compel the person's attention. So they become hyper focused on triggers in the environment, and that makes drives them to feel like they need the drug in order to feel okay. And then they take the drug, and taking the drug, this then provides immediate positive reinforcement as well as some negative reinforcement. And so it strengthens the habit of drug taking. And as the cycle recurs over and over, this becomes a habit, and potentially such a strong and powerful habit that the person consciously can tell you, I don't want to use drugs. I don't want to do this anymore. I know this is ruining my life. But then they continue to engage in the behavior anyway. Uh, and this becomes this self-destructive pattern. So the person feels this sense of loss of control. Oh, I'm sorry. The person feels this sense of loss of control, and and feels unconsciously compelled to engage in the behavior. So mindfulness really is the key to breaking that cycle, because first it brings awareness of the automatic habit of addiction, and then it brings the ability to gain some self-control over the habit. So, and that really derives from what mindfulness is all about, this practice of observing your own thoughts and feelings, body sensations, and then when you notice the craving arise, having an ability to manage the craving. And I could go into more details about how we do
Yeah.
that. But uh, but mindfulness is the key to becoming aware of the automatic habit of addiction and then disrupting it,
Mm-hmm.
because mindfulness is really a practice of gaining awareness of one's automatic reactions and then being able to regulate those. So
Yeah.
that's
No,
so
the
that's the
awareness.
first step. Yeah, that's the
I
first
was going to
step in the
mention that the
process.
awareness is everything. Absolutely. And being able to, I find that a lot of times when folks, whether or not it's with addiction or anger or whatever it is, at first they've got like that next day awareness, like, ooh, what I did yesterday wasn't so good. And then it like backs up to like maybe 6 hours post. And then and the golden spot is right. Can you see it in the moment or even preemptively feel like those precursor, like if you're feeling tense or you know it's gonna cue you. And I'm very similar. I use mindfulness personally myself. I meditate. It used to be daily. Now it's almost daily. I should get back to it. But certainly with a lot of the folks that I work with, being able to have that awareness in the moment enables everything else.
Exactly. So so the first stage in the process then is to cultivate this awareness, so the patient realizes, hey, I'm about to engage in this behavior, and it may feel like it's out of my control, but maybe I can inject some control, some conscious control into the process. And it also gives the person the ability to manage craving. And the way we do this is we teach people to use mindfulness to actually zoom into the craving and to deconstruct the craving into its subcomponent sensations. So rather than focusing on some terrible, awful, anguishing experience as a whole, we teach people to break it down into sensations in the body, like jitteriness or the heart racing or hands sweating. We teach people to become aware, to tease those sensations apart from the thoughts and feelings they're having about the sensations. Thoughts like, I've got to use, I can't stand this feeling, it's going to overwhelm me. And then we teach people to begin to notice that the sensations themselves are impermanent, that they're constantly changing. We call attention to the permeability of the sensations. So we ask people to notice, do the sensations of the craving have a center? Do they have edges? Are there spaces inside the sensation where there is no sensation? And in doing this, people inevitably begin to discover that the craving is not this monolithic, solid, overwhelming thing that they can't handle, but rather it's this fluctuating experience. And if the person becomes too overwhelmed at any point during this process, we guide them to turn their attention to the sensation of the breath moving into their nostrils as a way to calm down the mind, calm down the body, bring the person back to center. And then we encourage the patient to go back into the craving and to notice how it's changing over time. And in many cases, the craving begins to dissolve at that point. So that's one of the many mindfulness techniques that we teach in the MORE program, and I can tell you about others. But we're talking about the restructuring reward process, and so let me
Yeah.
tell you about how it unfolds from there. So then there's a whole other element, and this is more of the cognitive behavioral element, the element of reappraisal, of reframing or changing the way we think about uh, the objects and the events and the experiences in our life. And so there is this, in terms of dealing with craving, there is this element of reappraisal where the person begins to actively contemplate, what are the consequences of giving into the craving right now? How is it going to hurt me? How is it going to hurt the people that I love? And what are the positive consequences of not giving into the craving right now? How is that going to make my life better and the people that I love? And of course, these are things that people know. Obviously, people aren't fools. They know that there are consequences to these behaviors. But the issue is, I think, when the person uh, is stuck in the pattern of addiction, the automatic habit of addiction, in the heat of the moment, those are not the thoughts that are on their mind. Uh, and so part of the process is to consciously contemplate these consequences in the moment that the craving is arising, using mindfulness to create the kind of attentional focus and mental clarity that is needed to really deeply consider these consequences. So we teach this
Mhm.
approach uh, during the craving meditation. So really, there are two parts of the mindfulness of craving technique. The first is to use mindfulness to zoom into the craving, to break it down into its subcomponent sensations and thoughts and feelings, emotions, and to notice the changing of that experience over time. And then the second part is then to start to reappraise the craving by thinking about the consequences. And then finally, the sequence, the restructuring reward sequence culminates in the process of savoring. And so savoring is not something necessarily that the person is going to do in that exact moment when they're experiencing an intense craving. But but we also teach patients how to use mindfulness to focus on what is good and meaningful and beautiful in their life. And so to actually take time uh, to appreciate and enjoy the natural healthy pleasures that abound all around them, but to use the attentional stability and focus that we develop through mindfulness to really deeply uh, bask and relish in the goodness of that experience. And so,
Mhm.
and I can tell you more about that if you're interested too. But I think of these as sort of this kind of teeter totter balance where we're using mindfulness and reappraisal to tamp down the value of the drug. So we're making the drug less valuable, and then we're using savoring to bring up the value of the natural healthy rewards. And so then
Mhm.
we're just reshifting the balance back from valuing drugs back to valuing natural healthy rewards to help the person to reclaim that sense of healthy joy and meaning and pleasure that they once invested in the people, the activities, and the values they cared about that got stolen
Mhm.
by the addictive process. Now we're teaching people to just reinvest it and do the rebalancing. So that's the overarching concept, which I think makes MORE pretty
Yeah.
unique and pretty different from other therapies.
Definitely. No, absolutely. I think that when I think about the therapies that are run oftentimes in treatment centers, there may be some elements there, but not necessarily as cohesive or even tying it to some of these more psychologically driven mechanisms that are underlying where the addiction comes from. So something comes to mind though as you're talking about more. I know that a lot of your research has focused on opioids and then also particularly folks who have pain. And I'd assume in some ways that that's because of what's going on with the opioid epidemic and looking for solutions. But I'm wondering, have you tested more with other substance use disorders, and has it had similar impacts, or is it have you really just mostly been focused on opioids at this point?
Great question. And the short answer is yes. We've tested more. So the first trial of more, actually, which was my dissertation, was for people with alcohol use disorder. Um, but these folks, this was in inner city Durham, North Carolina, and in a largely African American population. And most of these folks were dual addicted, not only to alcohol but also to crack cocaine. So that was the first trial of more. I did a second trial of more versus trauma focused CBT in that same treatment center in Durham a few years later. Uh, and that was for people with really just a grab bag of addictions. We were totally agnostic to the substance. So we had people who were using everything under the sun. And they also
Mm-hmm.
had co occurring psychiatric disorders and trauma histories. And so in that study, we showed that more outperformed a trauma focused CBT intervention for reducing drug craving and PTSD symptoms. Um, and this was in a pretty rough population of folks. We did some pilot work on more for smoking cessation, and we recently are very soon to complete a neuroimaging clinical trial of more for smoking cessation, where we're comparing more to CBT and trying to understand what are the neural mechanisms, how do these two therapies differ from each other. So we don't have results from that yet, but it's about to be finished. And then we've looked at more as a treatment for behavioral addictions. So uh, a student did her dissertation on more for video game addiction and actually found really strong effects of more in reducing disordered video game use and video game craving. Um, so we have looked at more for different addictive behaviors, but you're right. Most of the work has been focused on opioid use, opioid misuse, and opioid use disorder, as well
Yeah.
as the comorbidity with chronic pain. And that actually, my new book is really focused on that particular group. It provides a very clear treatment manual to guide therapists in delivering this evidence-based therapy for those populations.
That's fantastic. I know as I'm listening to it, I'm thinking this sounds fairly transdiagnostic. You know, it seems like this would apply to a lot of different behaviors and substances, and I'm glad to see that the research is starting to grow. But also, here's a question then more about process and dissemination. So I think we're all very aware, even just on the mental health, behavioral health side of the tracks. If we don't even take addiction into it, it's very hard to disseminate new ideas or new therapies. And then when it comes to addiction, again, having been the director of an addiction service line in a hospital system, having been to a lot of treatment centers, it's very hard oftentimes to get systems of care to change, particularly in the addiction world, when folks might be very married to maybe what they themselves did as they recovered from an addiction, or even just what they've been doing in their treatment center for years and where they've got clientele coming in. So it's harder to necessarily make that business case of like why we should be transitioning something else in. So I'm wondering, from your perspective, as someone who clearly has something very valuable, you've developed a technique that works, you've tested in a lot of different places, it's theoretically sound. How do you go about getting it out there so that both practitioners and the public can take advantage of the technique?
I was going to ask you that question. No, I mean, I think that is the greatest challenge that we face as addiction treatment researchers who want to make our work actually matter and improve care for people who are suffering, and it's really hard. I mean, I can tell you about some of the stuff that I've done. I mean, obviously, the first thing is to just show definitively that what we have is valuable. That this is something that goes beyond what has been done before. And I think the data uh, from two very large recent trials of more, I think, are fairly conclusive in that regard. I mean, the first trial published in JAMA Internal Medicine showing that more reduces opioid misuse by 45% at a 9-month follow-up, nearly tripling the effect of standard group therapy. I mean, from a economic standpoint or policy standpoint, that should be enough, because it's just saying, hey, this is way better than what we're already doing, and at the same time being able to show, as we did, that more significantly decreased chronic pain, depression, and PTSD symptoms, all within an 8-week treatment. I think so. There's some arguments to be made that this is a resource efficient therapeutic approach, and actually we did a cost effectiveness analysis from this particular study and found that if you give more to a patient, that it's going to ultimately save over $300,000 across their lifetime. So I would hope that those kind of data are meaningful in terms of convincing the health system to uptake a therapy like this. I would also lean on our recent trial published in JAMA Psychiatry, where we added more to traditional treatment, standard addictions treatment for people with opioid use disorder. So these were folks receiving methadone in the community. And we found that adding more to standard addictions treatment reduced relapse by 42% and dropout rates by 59% relative to standard addictions care.
It's
So again,
huge.
so the data is strong, and it's saying, this stuff, if you bother
Yeah.
to do this, which does take time and it does take effort, and therefore on some level it does take money, then it's a worthwhile investment because it's improving treatment outcomes. But beyond that, how do you do it? You got to talk to a bunch of people, like I'm talking to you, and
Yeah.
I think that the most signal accomplishment, I guess, let's put it that way, that I've made in that regard is earlier this spring, I went and talked to Congress about more. So I went to Capitol Hill and spoke at the House of Representatives to the Addiction Treatment and Recovery Caucus of the Congress, and got to brief the members and their staff on this therapy. And that was a huge honor to be able to do it. And and I hope it does some good. So really just trying to get the word out at
Hmm.
the research level, to healthcare providers, to policymakers, and to patients. I mean, I think that's the best that I can do personally. Um,
Yeah.
and fingers crossed that it actually works. So
Yeah, well, then you need enthusiastic surrogates like myself to be like, hey, I've heard of this really great therapy that we could use to advance our system of care. And listeners, by the way, we'll make sure to put the citations in the show notes so that if you'd like to download the papers, if you have access, that you can do that. So here's a question then, though, because a lot of the listeners to this podcast are professionals. I know you have this book coming out about more specifically for folks who are also struggling with pain, so pain and opioid use disorder. Can you tell us a little bit more about that? But then also, because this is a broader potential technique, if someone was looking to apply more to more, we'll just say, addiction without pain or some other context,
yeah.
is that the place to go to, that book, or are there other resources they could look for to be able to, if they wanted to give more a try or to get trained in?
Oh, great question. Thank you so much. Well, so the original more treatment manual was published by NASW Press in 2013, and that book described how to deliver the treatment for people with addiction who don't necessarily have pain. So that's sort of the general more approach. Uh, that was 2013, so we've learned a lot in the past decade about how to deliver this therapy more effectively to make it better. And so the
Mm-hmm.
distillation of a decade of practice wisdom has really been uh, really really been put into this new book of mine. Um, so although the new book by Guilford Press, which is coming out in this month, is the treatment manual itself is focused on chronic pain, opioid use, opioid misuse, and opioid use disorder, uh, the the sort of distillation of the practice wisdom. How do we work the magic of more to be effective with our patients? That material is probably still useful to people who are working with patients who don't have pain, because a lot of this approach really is dependent on therapeutic artistry. How do we teach people mind body skills? And even more importantly, how do we process the learning of those skills so that it really makes a difference in terms of the patient learning how to help themselves address symptoms of craving and addictive behavior, emotional distress, and physical pain.
Hmm.
Also, the magic of more is in this processing approach is really relevant in terms of building the patient's motivation to engage in mindfulness practice and build their self-efficacy and help them uh, to believe that this practice is going to help them to have the therapeutic expectancy. And so that's really where the magic of more happens, is in the processing. Although most of more is a manualized therapy, uh, the part that really can't be scripted is how do we interact with the patient as we teach the skills and we start to inquire into their experience, um, to then get them to really extract all the goodness they can out of that therapeutic moment and to motivate future practice. And so that's really where the magic of more happens. And I think the best way to learn
Hmm.
that is to actually get trained in more. So the training in more is something that I've been delivering over the past number of years. So I've trained nearly 1,000 clinicians so far. So social workers, psychologists, counselors, nurses, physicians, all around the U.S. and internationally have been trained in more and are now delivering this therapy as part of standard of care. Uh, so that training, I think, is really key to doing this well. And so I think it's really the best way to learn this thing is to get trained in more, and then also have the book to have a script to guide you to implement this therapy in a standardized way. And so that's really what I would recommend. So if your listeners are interested in getting trained in more, the best way to learn about trainings is to come to my website, which is drericgarland.com, and there's information about training in more. I do a couple of trainings a year that are open generally to anybody around the world. Those are delivered by online by like a Zoom kind of platform.
Hmm.
But I also do agency specific trainings where I can come to an agency or healthcare organization and do a training that way as well.
It's fantastic, and it's such an important opportunity. And I know what you mean. You get a book, and it doesn't necessarily bring it to life, but if you actually can be trained in it from someone who's just done it, much less literally developed it, that gives you a huge leg up, because then you can use that book as more of that extension rather than the platform. Well, let's turn the question around then, from more of the patient side. If you have somebody, if someone's hearing this podcast or they hear about more and they're like, "Ooh, I've never done anything like that. Maybe I've been to treatment a bunch of times and nothing seems to stick, but I've never done anything that sounds quite like that." How do they find somebody? Do we have a mechanism to help hook them into practitioners at the moment, or is that still a little bit tougher from the patient side?
No, actually, I do have a directory of therapists who've been trained in more in the various places around the country and around the world. It's on my website. It's a link on my website, and I'm continuing to fill that out as more and more people get trained. So it's a work in progress, but you can go to my website now and start to see where you could go meet with a clinician who can lead you through the more treatment.
That's so useful and so fantastic. And it occurs to me as we're talking about this, have you just passed the point where you want to make puns off more, like more and more treatment? Like, I feel like there's so many opportunities, and the dad in me is like, oh, you should make a dad joke, but then I'm not doing it. Did that wear off like
You
12
you
years
already
ago?
stole you already stole my pun. I mean, there's no end to the number of puns you can make. There's always more and more.
Oh man, that was like a meta one right there.
A
Oh
meta
man,
dad joke.
a meta
That's
dad
pretty bad
joke.
when
Oh
you.
man, we're leveling up. Our eyes are going to start glowing or something. Oh, all right. Well, so as we're coming off the rails here towards the end, just I guess to wrap things up, I know the reason why I reached out to you is that I'm very passionate about social, population health level solutions and this idea of what we can scale. And I was looking at the work you were doing and thinking, like, man, like this is something where you can see the path forward for scaling. You can see that the evidence from the front end, how we can bring it out to folks. I was so glad to see that you were talking to Congress about that. I know that when they get their teeth into an idea, it oftentimes gets legs because it gets baked into funding decisions and programs. And so I'm very hopeful about that catching on. And you're obviously still publishing very prolifically in journals, and you have a book coming out. Um, so for you then, from more of like a research platform in your own work growth perspective, what are the next steps? Is it more of what you've been doing, or is it branch off and take more to more different places? Sorry, this is
there's the meta dad
yeah,
joke boiling in the
yeah.
background. Yeah, no, great question. So I think there's a few more things I wanted to talk to you about, and I'm going to try to weave these together. So so one thing that really interests me, and in a new direction of my work, uh, is some another facet of more that I think makes the therapy quite unique, which is essentially, from my perspective, when we're teaching mindfulness meditation to patients, we're teaching them to achieve an altered state of consciousness. And many of our patients are that's why they're using substances. They're seeking an altered state of consciousness, whether it's to alleviate emotional pain or physical pain or just to get high. They're seeking an altered state. Well, recently, 2002, we published a paper showing that when people go through the MORE program, these are people with opioid misuse, they go through the MORE program. Uh, when they practice mindfulness meditation, they actually are able to achieve self-transcendent states of consciousness where their normal sense of self uh, starts to fade, and they feel this sense of connectedness to the world around them, potentially even a sense of oneness with the world. And oftentimes in these moments, people are filled with profound sense of peace or joy or even bliss or even universal love, quite frankly. And now I'm not claiming that people are achieving full blown enlightenment as a result of the MORE program. Uh, these are novices with meditation who maybe have only been practicing for a few weeks. Uh, but when the patients experience even a small taste of this sort of self transcendent experience where they're connecting with something greater than the self, that experience during meditation produces a particular brain signature, frontal midline theta oscillations in the brain, and the greater the increase in this brain signature of transcendence, the greater the reduction in opioid misuse in the future. So that's a really exciting finding. And believe it or not, we've actually replicated this finding. We've shown it twice in two separate randomized controlled trials that patients going through the MORE program, when they practice mindfulness meditation, it can produce these self-transcendent sort of experiences, this altered state of consciousness, which is linked with increased theta activity in the frontal midline regions of the brain, and that brain signature has anti-addictive properties. So that, honestly, that really excites me, especially the fact that we've replicated it now, because it tells me that this could really be a very important mechanism by which mindfulness is reducing addiction. And so
Yeah.
so seeing that, one interesting direction then is to start to explore this more, and how can we amplify this what I would call missing piece in addictions treatment.
Mm.
Addictions treatment has traditionally been focused on removing the negative. We teach people how to avoid triggers. We teach people how to avoid high risk situations. We teach people how to decrease craving. We teach people how to reduce their stress. Uh, it's taking away, right? We're taking away
Yeah.
stuff, which we need to do. But what are we going to give people in return? How do we
Yeah.
fill the thing that's been emptied out? And if we can teach people how to access this inner wellspring of well-being and joy and, dare I say, pleasure and bliss that they've been seeking outside of themselves with an external drug, and the patient discovers that they can actually use their own consciousness to produce that thing that they've been seeking, they can produce it inside of themselves in an even a more satisfying way, then
Yeah.
maybe that's going to be the thing to really reduce the pull of the drug. And so we're exploring that in different ways with neuroscientific studies. We're also starting to combine more with psychedelic psychotherapy because we know that psychedelics have the potential to induce these types of self-transcendent experiences. And
Hmm.
so potentially the combination of a really rigorous evidence-based approach to addiction psychotherapy, like more, combined with the psychedelic assisted psychotherapy with a well-trained clinician, maybe that could make a big difference. So that's one
Yeah.
area that I'm interested in going in. Another uh, is sort of very in the opposite direction, which is to be very practical and to start to answer the question: how do we implement this thing in real life? How can we deliver more in addictions treatment in a way that works so that people can access it? How do we overcome the barriers involved? And is more effective when it's delivered in community-based addictions treatment as
Hmm.
part of standard of care. So we have two really large NIH funded projects that are doing that right now, and we're about to launch a third in the primary care setting where we're going to be delivering more as an insurance reimbursable group medical visit for patients with chronic pain who are prescribed opioids, but who the risks of opioids may outweigh the benefits for these folks. We're gonna see if we can get primary care providers to deliver more uh, in the doctor's office, bill to insurance, and if they can do it effectively and how to overcome the barriers there. So there's a whole line of implementation science that we're doing um, to try to get at that. And,
Great.
yeah, and then the last direction is really trying to understand how do we how can we change the brain to help heal addiction? What is more doing on a neurobiological level? We've done a fair amount of neuroscience work on more. Most of it has been EEG, where we're measuring changes at the surface of the cortex. But we want to know, really, to test this restructuring reward hypothesis, we need to go deep into the center of the brain, into the limbic system and into the basal ganglia, the striatum, to see is more really changing the way rewards are being processed in the brain. And so we're doing some of
Mm.
that work now in people with heroin addiction and also with cigarette addiction. So so those are a bunch of future directions that we're taking this work in, and it's all really exciting to me.
Yeah. Wow. I mean, so many different arms, and I appreciate the fact that you're getting at both like the why does it work from a neurological level, from the psychological level, but then also thinking about, well, and this is really what I get passionate about is how do we actually get this in the hands of people, right? Implementation science, as you call it, right? Because you could have the best idea that if no one picks up, doesn't go anywhere, and so, but that is oftentimes a whole different side of things then does it work in the first place, but ultimately just as important, if not particularly more so. I'm thinking about like you mentioned psychedelic medicine and thinking about some of those paradigms. I know one of the reasons why I personally would be more excited about more would be that it's the way that at least currently psychedelic science is being structured with perhaps a little bit of difference on ketamine, although we don't have to go down the rabbit hole, is more of like individual administrations, right? Like let's do this once or twice or three times, and then have an integration sessions, and then ideally you'd see a lasting benefit. But what we're talking about is having with more is something where you could produce a self-transcendent state, maybe not reliably every time, but semi-reliably, right? Is the idea is that you could actually achieve that sense of peace without that external assistance, and that could be something that you could do that also wouldn't have necessarily an impairing effect for say 6 to 8 hours or something like that. So perhaps more of the
Absolutely.
positives there.
Yeah, totally agree with you. And that really excites me that we have data showing that you can achieve maybe not the same experience, but you can achieve a, a comparable experience or a taste of that experience without taking any drug, but just using self-regulating, using your own consciousness to achieve this experience of profound peace and fulfillment, which of course is really what these mindfulness practices have been about for thousands of years traditionally. Um, but I think it's now time to go full circle back to that, and that there's more, pun intended, to this than than simple stress reduction and becoming more attentive or more present. But actually, there is this other plane of of existence that when we tap into it, it can be profoundly healing. So that yeah, that gets that's one of the things that gets me up in the morning to do this job. Take it to the next level. Um, but I think it also paves the way for other therapies, like combining more with neurostimulation, neurofeedback, really integrating psychotherapy with neuroscience informed therapeutics to develop a more powerful approach. So I think this problem is so huge that we're facing in this country. We really need to tackle it from multiple angles, and that's what I'm trying to do in my line of work.
Well, we got to call it a day for now, but it sounds like you have plenty to do for at least the next 20 to 30 years, maybe 50. You're going to have to have somebody carry the torch, so many different angles. But Dr. Garland, thank you again so much for coming on the show today. Truly appreciate it.
Thank you, Aaron. So nice to talk with you.